Do you have any mindsets that you use kind of on shift if you feel yourself kind of getting to that point to avoid the cynicism and the things that come with burnout, or things that you tell yourself or anything like that?
Yeah, I do. I usually just try to step back and sometimes I'll just say, this is somebody's baby, that's in front, like just to try to get a little humanization of maybe someone I'm having a difficult encounter with. And then some of it is just that gratitude and awe of, this is temporary. This is a small part of my day.
Mm-hmm.
I'm very grateful that I have, warm home to go home to, just list your things you're grateful for.
Yeah, I think that gratitude is huge. I think that's something I try to do every day, is go through a list of things I'm grateful for. We all have little things going on outside of work, and you can bring that into work if you ruminate on it. But, if you can count the things you're grateful for and focus on those as opposed to the problem you're dealing with or the difficult patient you're dealing with in the moment, I think that is huge. It helps put it in perspective. Like, this is a small part of my day.
Right.
It will pass, And then it helps you be a better provider because you can focus on what that patient needs and not write them off and be cynical about it. And cynicism is a big problem, I think, in our line of work. And it's something you have to constantly combat in others around you so that they don't bias you against a patient or cause an anchor bias on somebody and then you miss something. It's a constant thing that you have to wrestle with, I think.
Yeah, absolutely. I mean, I've had staff tell me, oh yeah, this person's here all the time, and then you go back their chart and we haven't seen them for a year and a half.
Yeah.
Okay, maybe they have a chart and a different name, but maybe not, Yeah.
That's one thing I try to stress to the EMS crews is not to pass along that anchor bias. And they give us a wealth of information, and often they've been with the patient for an hour and they may have seen things that we're not going to be able to see and their living situation, things like that. But I try to emphasize, like, you guys don't get to see the end of the workup a lot of times. This person you're convinced is having a panic attack ends up having a PE, or this patient that called you because they've been vomiting for a few hours has appendicitis, and they don't get to see that continuity of care that I think we get to see much more frequently. And that helps humble you pretty quick against writing people off and doing your due diligence on patients.
Yeah.
So I really appreciate when they come back in to follow up on a patient and I can tell them, like, yeah, I mean, a PE will make you very anxious,
Right? Yeah.
but it's not a panic attack.
And hyperventilate. Yeah, but it's not a panic. Well, but I love the information that the paramedics can give me about the scene and the patient and everything else during that. I mean, if they're coming from security, they've got half an hour, 45-minute transport, and that's huge. I love that information that they can fill in. And do they live by themselves? What did the house look like? And all of those things are really important information.
Yeah, and I've seen you take report from EMS crews, and you do a great job of slowing things down and listen to their full report, which I think a lot of providers struggle with. We're in a very high volume setting most of the time. We don't have a lot of time with each individual patient. And when an EMS crew's rambling a little bit, a lot of physicians, PAs, NPs will cut them off and just get down to the nitty gritty. And they don't give them that room to kind of talk through things. And that could be from your EMS background. You and I probably remember what it was like to give that handoff report and be dismissed or be cut off halfway into your report and be like, I was getting to the question you just answered. It might take me longer than you like for me to get there, but I was going to answer, are they on blood thinners or whatever? And so I think it helps when you have an EMS background to give them that space to tell the story. And then you recognize too, when it's a brand new EMT and they're nervous to talk to you. And I think you recognize that right away. And you're like, okay, I'm going to give them a little space to perfect a skill that they're still developing, and
yeah, I try not to call them on it too much, like there's no external rotation or shortening, like, well, looks like it to me. That's what we would call it, right?
Yeah.
But yeah, I do wish that they wouldn't wait until the patient gets all the way transferred to the bed after the security has taken them and everything else. Cause it takes it doesn't seem like much, but it takes 3 minutes,
Yeah.
and I got pulled out of a room, to be here watching you unhook the belts. We could talk in the hallway.
No, that's a great point for EMS crews. Like, if the doc's in the room and we have a transfer, go ahead and start giving the story. We don't have to wait till they're all settled in a bed, which is going to take several,
Right.
Launch into the story,
Yeah. And I like it. And you can tell the more experienced ones usually will just start, especially if I'm following them down the hall to the bed to start with, let's just chat and make use of this time.
Yeah.
So, yeah.
Yeah. Unfortunately, our time as providers in the ER is a very limited resource. So you have to, for them, they've had the one patient. I remember what it was like. It was great having one patient at a time. You're from start to finish, you're with one patient for an hour and you have an abundance of time. And I think the more we educate them, we don't have 20 minutes to get a story on a patient. We've got 12 other simultaneous patients we're dealing with. And some of them just truly don't know that workload. And so I think the more they understand about our day and what our day looks like, the better they are at kind of making a concise history and delivering it quickly and efficiently, And
early.
And early, yep. Early. Yeah, no, I think that's a great point. Yeah. What advice would you give or have you given to the new ER physician or even the new PA or NP when they're brand new to it? Is there any particular pieces of advice you think are really helpful for them?
I think from a clinical standpoint, not coming to premature closure on a diagnosis is huge. And it's really easy, especially I think for the APPs, because I think they come out of school with less time at the bedside. And so they probably haven't seen all of that. But yeah, so I mean, I think a lot of it's the humility of not being afraid to ask questions, not being afraid to ask somebody for their opinion. The other big part of it, though, is financial. And I think that this is huge. It's like when people come out, if you can stay at an earning level that's close to what you were in school and pay off your loans rather than buying the biggest house, the fanciest car, the biggest toys, because the people I see that end up with that kind of debt end up a lot of times either feeling like they're a slave to their job. Yeah, I don't. Anyway, that's more for my colleagues. But yeah,
no, and that's a great point. I think even for PAs and stuff, it's still. All of a sudden your income's much higher than it was when you were a scribe or whatever it was before you went to PA school or NP school. And it's very tempting to buy a bigger house and buy brand new cars. And then all of a sudden you have to work as opposed to, I think that lifestyle creep at the physician level or even at the PA level is a problem. Yeah. I think living below your means really does help with burnout because when you have to work 18, 19 shifts a month, that's a very different scenario than being able to back it off and work a more reasonable amount of shifts.
Yeah.
Have you cut down on the shifts, the amount that you work overtime? Have you stayed at the same level?
I've tried to cut down. So I've cut down several times and then we end up being short staffed. But yeah, I'm working less now than I did for sure. When I started, we were hospital employees and there was a minimum number of hours that we had to work. And so it's less now, which is good. Yeah.
Yeah, I think that's a good thing to work towards over time. And such a big component of it is not having that lifestyle creep, I think. Yeah, I think cutting down over time in the ER is important for your mental health. And for me, like the first year and a half, it was such a steep learning curve as a PA with no ER residency and being a paramedic before. I'd seen a lot of emergencies, but the way you think about how long you're taking care of a patient and what the next steps are very different. But that first year and a half, the stress level was like, it peaked at a certain point, but then it doesn't really get easier either. Like each shift, I've been doing it almost 6 years and each shift is still very challenging, both because of the volume we see, the complexity of patients that we see, And so one way I think to fix that is just by working a little bit less when you can afford to, and over time and gradually. And, because the stress level I feel like doesn't go down much over time. I don't know what your thoughts are after close to 40 years. I mean, but I feel like there's a baseline now that probably is not going to go down any further.
Right. Well, I mean, there's always unusual presentations of disease, but yeah, I think eventually it does go down a little bit, and that's a good news. Yeah.
Is there anything you see about new physicians or even new APPs that are different mindset wise than when you first got in the field?
I mean, the whole trend towards productivity is something that's happened. I mean, it was always there in terms of, are you seeing enough patients an hour? But so that's a little bit different. I have to say, though, I really respect my younger colleagues and all the skills they have, like with ultrasound and the computers. And I am impressed. I'm proud of them.
I'm sure you've gone through, I mean, technology, even since I've been there, has changed, now we're using AI. And I mean, there's so many things that you have to be able to adapt to. Have you found that there's a lot of changes you've had to just be able to adapt to over time, I would imagine?
Yeah. I mean, I think the charting part has been the most of an evolution. Like when I started, we wrote SOAP notes, as physicians. And then we went to this little dictation thing where we could talk into a microphone, which was great. And, send a little tape in, very much like the AI stuff. And then you just had to sign your charts later. But there was a human that was correcting it. So if your grammar or your spelling wasn't, it wasn't my spelling, but if your grammar wasn't right, they would correct that. And then we went on to all these electronic medical records, which I'm really hopeful that the AI dictation will help us with. But yeah, I think the burden of the electronic medical record and having to input our own orders. I mean, it used to be like when I started, I could either write on a piece of paper and the clerk would do everything that we wanted to do, or if it was a trauma situation or resuscitation, I could just give verbal orders. And now I have to look on the computer, find the right code. I have to find my diagnosis code, put it in, and somebody else did all of that before. So that was hard.
Yeah, that's interesting.
The other thing that was interesting is like we went from, so when I started, we didn't have ultrasound. We didn't really have a lot of CT capability either. A lot of the places I moonlighted didn't have a CT scanner. So we do peritoneal lavage to see if somebody had a belly from trauma that needed to go to surgery from like a motor vehicle accident. So we put a needle in, see if we got 10 milliliters of bright red blood. If we did, they went to the operating room. And now that's been replaced by ultrasound. So it's... I mean, it's kind of fun, some of the procedures that have just died off like that you used to do. Coldocentesis, oh my God, thank God we don't have to do that again. But for ectopic pregnancy, you used to have to put a needle into the, basically the back part of the vagina near the cervix to drain off blood. That was a brutal procedure. So I'm glad that's gone too. So yeah, there are a lot of things that have evolved.
I imagine you relied a lot more heavily on your physical exam just because of our quick access to CT imaging now it's such a low barrier. Most people are probably going to get a CAT scan if you're even mildly worried about a surgical process in their abdomen. Whereas before, I'm sure you spent a lot more time assessing their abdomen, percussing or, whatever. And because you had to be much more judicious on if I'm talking to a surgeon about this patient or something.
Yeah. But then the surgeons were more open to it too. I mean, if you had a 12-year-old boy with right lower quadrant tenderness and a white count, they would just take him to the operating room. They wouldn't have to do all of the other stuff. And I think that they had different standards for what was a an okay, miss rate is what they would call it. But the serial physical exams are largely gone by the wayside.
Yeah.
Yeah.
Yeah, I imagine our miss rate threshold now has got to be much lower. I'm sure the hospital, especially the big hospital systems, probably have much softer standards on that kind of stuff, just because they're going to ask, why didn't you get the CT scan on this patient? And
exactly. Yeah. Why didn't you, obs them or whatever? Yeah. But yeah, it's interesting. Yeah. I mean, I think overall, especially during COVID, as much as we had to change everything, I mean, like twice a day, sometimes we were turning and pivoting, the quotation marks of, what we're doing. That was really the time that had the most changes and the most short, we never had shortages of anything before either. And so I think that's really challenging too, is to try to figure out, okay, if we don't have intravenous benzodiazepines, we use phenobarbital for withdrawal now. And so,
yeah, I feel like it's interesting that there are periodic shortages of just different things you would never think should be in a shortage, but then you've got to kind of modify your practice and still try to do the right thing. Contrast is a recent one where we're doing a lot of non-contrast scans, which the surgeons really don't like. And you have to think, do I need contrast on, you have to ask yourself questions you wouldn't have to ask before. Even the IV fluid shortage, you have to ask yourself, would I give this patient IV? Do they need IV fluids? Can they just drink something? Because most people have that expectation. If they're getting an IV, they're going to get fluids hung. And so you also have to talk with the patient and be like, well, we're not giving you IV fluids because you can drink fluids. And it was such a standard thing, no, just order IV fluids on everyone. And all of a sudden you've got to ration, a limited resource that doesn't make sense to me. Like, I can't imagine how hard IV fluid is to create, but apparently it's something that could be in a shortage,
Yeah. Yeah.
What are some of the biggest things that still give you meaning after doing this for so long on a day-to-day basis?
I really love making a difficult differential diagnosis. That's like really, that's a fun thing. And then I think just the interpersonal connection, if I can go in a room with somebody who seems pretty skeptical and turn it around to where it's positive interaction, that feels good.
Yeah.
I love the teamwork of the ER, I really do. So that's good too.
Yeah. Yeah, I think there's a lot less belittling maybe than there used to be of, someone with a less education level. And obviously the incorporation of APPs in the ER has been a big thing too, but try not to belittle the EKG techs and listen to their opinions on something. I mean, they may have stood in the room longer than I did to get this EKG, and maybe they noticed something on the monitor that I didn't notice. And so I think it's a big part of that teamwork is making sure that people, regardless of their education level or their role in the ER, projecting that affect that you're approachable, and so that people can bring concerns to you. The nurse can bring a concern to you instead of being like, oh, I don't want to bug that provider because they're not going to listen to me. Because I try to project that affect of approachability so that if the nurse has a concern, they're not going to blow it off because they don't want to talk to me. They'll say, hey, this patient isn't looking like they were when they first rolled in the door. You haven't been in the room in an hour, but I've been in there a few times and they're not looking so hot. Because that's helped me out immensely quite a few times. The nurses are at the bedside more often. And so I think part of maintaining that good teamwork mentality is trusting people.
Yeah. No, and that is actually a piece of advice that I would give is anytime the nurse tells you there's been a change and they're approaching you with a concern, go into that room, see that patient, because, don't let them try to handle it on their own. I mean, sometimes you can't.
Sure.
We had a situation where I was tied up with a trauma that you went in and checked on a patient, thankfully, that the nurse had a concern on. And that's great. That's the whole teamwork. Yeah. But
yeah.
Yeah. I think when you hear that concern and that legitimate, then it's time to just go in. And sometimes it's just miscommunication to one provider or the other.
Sure.
And that's great. We can clear that up pretty quickly.
Yeah. Yeah, and sometimes it's a good education opportunity for the nurse or something, and you can say, "Oh, this is why they look a little bit different now. Thanks for grabbing me, but I'm not concerned." And then there's the scenario where you're like, "Oh, if they look much worse, let's move them to a resuscitation bay."
Yeah. Oh, that is a focal seizure. Thanks for noticing that. Yeah.
Yeah, that's a good point. Is there anything, we kind of talked about how it can be therapeutic to interact with people that don't see all the meth that we see. Is there anything that you feel like the average layperson should understand better about our role in the ER, or that you think should be communicated to the average person?
I mean, it's one of the things that I think that being in the ER and seeing experiences is, I don't know if I have a piece of advice for people other than there's a whole wide world out there that people have no idea exists, that we deal with on a daily basis.
Yeah.
Yeah.
Yeah, we see a whole side of the world that most people never have to see, never would see. We talk to EMS crews a lot on the podcast. Is there any advice you'd give the new EMT or paramedic that comes in? And we try to give them real-time feedback, but we just don't have an abundance of time in the ER to always give them real tactful feedback. Is there anything you've seen recently or trends that they have that you would speak to for the new EMT or paramedic?
I feel like the new EMTs and paramedics are being thrown out with, a lot less maybe experienced oversight. I don't mean that in a bad way. I just mean I feel like they're kind of figuring it out on their own without having a mentor to really help them. And I would just ask for them to reach out and ask for feedback and get, feedback. Do you think this was good? Do you think this was bad? Because if we're really busy, we're not going to tell them. And I don't want to give them something that might be a negative feedback in front of their whole crew when I don't have time to pull them aside. So that might be a good thing just to have them, ask.
Yeah, that's a great point. I think encouraging them to seek that feedback, even like later in the day, because it's so hard to ask them, why did you do this? Because I remember being a paramedic and your instinct is to be indignant when someone questions what you did on a patient. Because usually there's some kind of rationalization or justification for why you did something. And I can remember, if a doc would ask me why I did something, your immediate instinct is indignant and trying to justify when their intent is just to help educate you about something. And it's so hard to do in our setting in a tactful way. And you make a good point. Like, it's usually in front of a bunch of other people, their EMT partner, the nurse. Because I can remember getting indignant about, when the nurse would ask me if they had an IV, and my instinct would not to say, no, there's no IV. It would be, well, we were just down the road. I tried, but I couldn't get it. The road was really bumpy. And you would start to justify instead of realizing that the nurse just needs to know if they have an IV so they can start one if they need to start one,
Yeah.
And so it's very hard, I think, to educate in real time the EMS crews without coming off as like criticizing their medicine. So I think encouraging them to come back, check on your patients when we're not in that moment, and I can talk to you one-on-one. And then if there is something that I disagreed with about your treatment, we can have a little conversation about it. But it is very hard to do, so that it's really on them to kind of come back with that kind of humble, teachable affect, I think. Because you made a really good point that there's not a physician riding with them on the ambulance. It's kind of you and your EMT partner, and you can't really better yourself with that kind of feedback if you don't actively seek it out. Because I can remember being an EMT and paramedic, you don't really get feedback on the majority of your patients. So if you're writing every one of them off, think nobody has a real emergency, you often don't get that feedback. Whereas in the ER, especially as a PA, I'm working with a physician. And so if my judgment on a patient or my physical exam is not an accurate representation, I get that feedback very quickly. The doc is like, well, I'm worried about him because of this and this. And you're like, oh, I totally missed that on my history taking or my physical exam. And you learn very, very quickly. And we see such high volume compared to what they see on the ambulance too. You learn very quickly, because we see thousands to their hundreds, and the learning curve in the ER, working in the ER physically, is very different than on the ambulance because of the volume. And the specialist or just the ER physician I work alongside, you tend to get that feedback pretty quickly. Like, oh man, we admitted this patient that I thought was fine to go home, and and that teaches you really quickly to see where your blind sides are. And I think that's a problem for EMS, is it's hard to get that feedback to know where your blind side, your misses are. You just don't get that real-time feedback. I think that's a good point, that they should seek it out.
They should seek it out. Yeah. The other thing I would say is, in terms of pain relief, this just might be what they carry on the ambulance and what they don't. But if somebody has an obvious fracture, you could just give them the narcotic,
Yeah.
You don't have to give them ketamine so they can't talk to me. Or Toradol, and they might have some kidney impairment that you didn't realize, but I don't know what they're being taught in paramedic school and what their standards are, if it's really hard for them to give, I don't think they have morphine anymore, fentanyl for the pain. That's the one trend that I've seen. It's just kind of like, well, what, you could have just given them pain medicine.
Yeah.
I would. This hurts.
Right. Yeah. The ketamine thing was an interesting one, because I was kind of in a transition from paramedic to PA at the time. And sometimes they had a great protocol for using small dose ketamine just for pain relief. But sometimes, every patient reacts to it so differently. I think that's why they don't use it I don't think they have a protocol anymore for pain for ketamine, because you might completely make the patient unintelligible and they can't give you any history anymore when you're just trying to treat their hip fracture pain or something. And all of a sudden now we can't talk to the patient or assess them for an hour. And we're like, because I would have that a couple times. Patient with an obvious fracture, and I'm like, oh, we have this great dose of ketamine I can give them that seems like it works. And about a third of the time it worked great. Their pain would be completely under control and you could still have a conversation with them. And then I felt like it was close to 2/3 of the time you would give it and then they're having PTSD flashbacks or something. And now you've made a situation much worse. Now they're in pain and they're having a psychotic break. And I remember the physicians getting mad at me sometimes, like, why did you give them ketamine? I'm like, well, we have a protocol. It says we can give it for pain. But I think it's probably good they've transitioned away from that to the classic opioids, where we're not knocking a patient completely out and they're still accessible.
Still accessible. Yeah. Especially the elderly people. Yeah. Yeah, they probably really shouldn't have the Toradol.
Right.
Yeah.
I see, Toradol occasionally given for someone who we've got to rule out a head bleed on them. And like, well, it's not really, in the ER, we don't give Toradol if we're, making sure they don't have a head bleed. And some of that might just be a education piece, and we see so many patients and we have the luxury of being able to, I can check someone's historical kidney function real quick before I give them Toradol to know that I'm betting on the fact that their kidneys are still okay. And sometimes I don't think the education's quite there to think through all the side effects of giving Tylenol to a liver cirrhotic patient or Toradol to a patient that's coming from dialysis or something like that. They just see it as, okay, they don't have a broken bone. Let's give them something for pain. But there's still contraindications that maybe they're not thinking through every time. I think that's a good education piece for the EMTs and paramedics. They have more options for non-narcotic pain relief now, which I never had when I was on the ambulance. It was kind of narcotics or nothing. We had no Tylenol or Toradol. But now you've got to think through, what are the contraindications still for this medicine? Not every patient, Toradol, Tylenol sound pretty benign, but you've got to still think through the other ramifications of giving those drugs.
Yeah. The Tylenol. I mean, I love that they have the Tylenol, and it seems to really work. So I'm glad that they do that. Yeah, the Toradol. Be nice to. I mean, I feel like if you're going to give a medicine, you should know who not to give it to.
Yeah, it's more important than really knowing the right time to give it. It's knowing all the wrong times to give it, because then you can kind of filter through and rationalize when it's okay to give it if you know all the big red flags of the patients not to give it to. And again, that's something I learned in the ER more so on the ambulance, because a lot of times these crews don't get that feedback of like, I wouldn't have given this one Toradol, like, just so you know. Because again, if I say that in the room, they're going to get probably indignant, maybe offended. And I'm like, I don't mean it to offend you. And you probably did this patient zero harm. Like, I'm not trying to say you harmed this patient by giving it, but in the future, like, that's not something we standard order if we're getting a CT scan on someone's head. I wouldn't jump to Toradol right away. Maybe give them the opioids if they're hurting, Yeah,
if they're hurting. I mean, one dose probably, even if, isn't going to be the bad, but